Hello, my name is Amy Lyons, and I work at Boston Children's Hospital, where I am the Director of Nursing for the Medical Surgical Intensive Care Unit. I'm here today to speak with Dr. Martha Curley about parent presence during invasive procedures in the ICU. Dr. Martha Curley is on faculty at the University of Pennsylvania and a nurse researcher here at Boston Children's Hospital.
Thanks, Amy. So our work here really didn't start with parent presence during invasive procedures and resuscitation. Having families be present within the pediatric intensive care unit has been a phenomena that's been evolving over time. In the early days of pediatric intensive care, we feel very comfortable not having families be present at all. So over time, and with our acknowledgement that parents really can be helpful to their children when they're critically ill, families were welcomed within the intensive care unit. Welcoming meant at that time that they would come in and that they would stand at their kids' bedsides and really not really do too much other than stand there and try to interact a little bit with their kids while they were critically ill. How parents learned to be present, they kind of observed other people in the room, other parents, and their role gradually changed from this very passive person who was present to really being acknowledged for what they were, parents to critically ill children. And a lot of work in nursing research supported the phenomena that parents really did transition from parent of a well child to parent of a sick child. And the purpose of what we all do as members of the clinical team is help parents find a role that they feel comfortable with and incrementally help them over time. So the phenomena or the evolution of families being present within intensive care units has evolved over time to a point that they were there for mostly everything anyway, but they were there with little preparation and with clinicians varying their practice and helping parents to be present to a variable extent. And so what would happen on the day shift was different on the night shift. What would happen when one attending group was on would be very different when another attending group was on. And it got to be very disorienting for families. So here within Children's Hospital Boston, we have a strong nursing science program where we take all staff nurses who are interested in asking and answering clinical questions that are important to their practice. We put them through Nursing Research 101 and we help them ask and answer questions. Well, during one of these courses that we were running, every single nurse from different intensive care units who were there voiced that we needed to do something different with families. And nurses in the cardiac ICU, in the medical surgical ICU, really were concerned, and also the NICU were concerned that parents were coming and they were ill prepared and they were witnessing things that they were concerned about. And they wanted individually to design studies to help parents be present during invasive procedures and resuscitation. So during one of these courses, as these three individuals were working separately, as the nurse scientists, we bundled their efforts into one larger study, and we saw the opportunity to change a system which had been incrementally allowing parents to be there, but really helping them to be present and to decrease variation around that.
Great, thank you. Can you tell me a little bit about your pre-survey work before the intervention?
Well, you know, it was interesting because there's, previous to our research, there were a lot of survey research in a lot of little pockets of places and disciplines. And we really wanted to get to what the core attitudes of the environment was across multiple disciplines, across the multiple intensive care units that we have here. And we knew that, you know, what people say they do and what they actually do are very different. And so we knew lots of what we had to change were perceptions around parent presence and also the practice of parents' presence. And so we decided that we would design a study that essentially was a pre-test, post-test, study that was conducted over 4 years. And And we specifically surveyed all clinicians who touched parents and children in the intensive care unit on their attitudes. And we also asked them during the pre-survey what kind of support they needed to make this transition happen. And so it was really, we looked for physicians and surgeons and nurses and therapists and social workers and clergy. We really wanted their opinion on what they perceived were important pieces that needed to go into the intervention. And then we actually surveyed practice in a pre-survey. We had one nurse who was essentially on workload disability. We had that one nurse trained to really scour the intensive care units looking for a wide range of procedures that were being done on the patients, and survey not only the people who are doing the procedures, but also the parents, because we wanted to understand multiple disciplinary perspectives, but also what the parents themselves were saying. What was helpful, what was not helpful, whether or not it was traumatic for them, whether or not they would do it again if they were given an opportunity. So we kind of did that pre-survey to really give us a floor of practice. And what was unique about our paper was that we had over 70% of people touching patients in our intensive care units from multiple disciplines participating. Prior to that, there was, wide variation in the, how many people participated, or it might be just one discipline's opinion. Mm-hmm. But we really saw this as an opportunity to change practice of multiple disciplines, because that's the parent's experience. The parents experience care from multiple disciplines, and so we needed to move the whole practice forward, not just within nursing, not just within physician practice or in therapy practice. So we felt it important to get their perceptions and also exactly what was happening in practice.
Thank you. Dr. Curley, can you please speak to the practice guidelines that were developed?
Oh, that was the fun part. The fun part was, from a disciplinary lens, nurses function well with practice guidelines, and we like to have at least a guideline to decrease some of the variation in our practice. But to get the multiple disciplines in a room and talk about what the practice should look like was really kind of interesting. We had, for example, we had our chief nurse exec, Patty Hickey, participating. We had directors of the intensive care unit, like Peter Lawson, participating. We had one of our surgical general surgeons involved, Jay Wilson, participating, and we had respiratory therapists participating, and then we had clergy, and we had our psych and social work staff, and obviously we had all levels of nursing, from less experienced nurses to our more expert nurses participating. And really what we did is we put everybody in a room, and it took months to really get agreement on what we were going to, how we were going to set up the environment to really help parents be present for their kids, how we would go through a consensus process before the procedure, if we could do that, how we would reach consensus, and how we would help parents be there, what kind of information we would give parents, and really give them an opportunity to say, you can stay if you choose to stay, and if you choose to stay, I'm going to help you stay, and these are some of the things that I can do to help you stay, and if you choose to leave, that's your decision as well, and we will keep you in the communication loop around that. So we had to set up the guidelines so that we would spell out, the roles and responsibilities, the decision-making model from a multidisciplinary perspective. And I think it's probably one of our few multidisciplinary practice guidelines that really took a lot of effort on everyone's part to do, and everyone's willingness to trust their colleagues' judgment if they hadn't had that experience. But it took a lot of time and a lot of effort on multiple disciplines to come together, and we created 2 practice guidelines. One practice guideline that was specific for parent presence during invasive procedures, and then one guideline specific on parents' presence during resuscitation. And the reason why we split the guideline was because we really left it up to the clinical team to decide whether or not they wanted to have a parent facilitator be present during the invasive procedure, whereas during resuscitation, we really wanted to make sure that we had a family facilitator be present for that. And that's really the only difference between the two guidelines. And currently here, we help parents to be present for all sorts of procedures, except for major surgical procedures that require big operative fields at the bedside. Those procedures, we help parents be present to the point that the child is inducted into an anesthetic level, and then we help parents to separate from their children.
Martha, you talk about supporting the parent at the bedside, and this is the new facilitator role that was developed. Can you talk about the training for this role and what the responsibilities are?
Yeah, prior to creating the formal role, what happened would be, things would start happening at the bedside, and whoever would be available would be grabbed into the situation to be with the families. And sometimes, we would not have anybody specifically there available to take care of the family, because obviously everybody, all hands on deck to take care of the patient situation. And so some of the obviously more invasive procedures or resuscitation, we really needed to have somebody there that would essentially take care of the parents and to help them be present for their children in any way that they want to be present. And so what we did was we created the role of the parent facilitator. And originally when we envisioned the role, all of our level 2 and 3 nursing staff, who are considered our more proficient and expert nurses within the system, were trained during leadership conferences on the dimensions of being present, how to introduce yourself to a parent, how to take clues from the parent, how to best support the parent, when to touch, when not to touch, to be able to better assess where parents are during the procedure. So we identified that there needed to be a formal role and what the role components would be. So right from the beginning, we elicited the help of Elaine Myers, who's director of the PERKS program, which is a program to enhance relational and communication skills for our staff here. And that program was crucial, I think, in creating a safe environment for clinicians to come in and, through the use of actors and actresses, learn how to interact with a family under distress who were obviously stressed to the max, observing some very complicated procedures being done to their children. And through this PERKS program, Elaine, which currently still runs today, along with Beth Trainer and along with Chris Rowe, who run the program, which is open to all the clinicians here, extended it out from the staff nurse 2s and 3s to members of clergy, psych and social work staff, in addition to any physician staff who would like more experience in a safe way learning how to interact with families under stress. And so the parent facilitator role, although it wasn't new, because the emergency room programs have been doing for a year, was new to the PICU, to really have a formal role, some formal education around that role, help people learn to do the role in this very safe learning environment that's run by, Dr. Meyer and Dr. Meyer's team, to really give people the skills that they needed. So within this simulated environment, staff could pick up what they needed. But as I said, we really wanted that facilitator role for parents who were present for their kids' resuscitation. And that was the intervention. So our pre-post evaluation was really staff attitudes and practice before and after the implementation of the practice guidelines and this family facilitator.
Great, thank you. Can you speak to the pre and post results?
Yeah, so what we were interested in measuring was not that, more people were present, or essentially forcing more people to be present. That wasn't what we wanted. What we really wanted was the clinical team who were involved with these procedures to feel more comfortable asking families if they wanted to stay and help them be present, and to help families feel better supported through the procedure. So that was the outcome measures. The outcomes were, are we having parents be present, feeling better, feeling supported and feeling comfortable with the opportunity to provide more options to families. And interesting results is that we found that it worked. It really did help clinicians feel better about their decisions. They felt comfortable in giving options. Parents, we didn't change parents' attitudes at all. Parents continued to want the opportunity to be present. They felt they had a right to be present. And it really didn't change parents' perceptions. It really changed the clinicians' perspectives. And what we also found was that parents were present through more invasive procedures. Previously, they would be asked to be excused, or they would be excused from rooms that were having pretty invasive procedures. But even now, parents could be present, for example, during chest tube insertions, central line insertions, and it's a given that they will stay if that's what they want to be able to do. So I think the implementation of the practice guidelines, the parent facilitator role, help clinicians feel comfortable in providing the option through more invasive procedures.
In the article, when you look at Table 3, was there any profession that stood out more than the others for change?
Well, we saw a change across the board, and there were significant differences pre-post in almost every discipline. The only category where we did not see a significant difference, there was higher level of satisfaction or higher levels of comfort, was in the respiratory therapy group. And I think it was because that group particularly was underpowered. So if we had more respiratory therapist participation, or we had more respiratory therapists in-house, we would have seen that. But all in all, we saw across the board improvements in their level of comfort in providing the option. So, that was an important finding.
In the article, you state that the parent facilitator role actually benefited the clinician more than the parent. Can you explain that?
Well, if you think about it, when you're at the bedside and you have things going on at the bedside, and you also have things going around the bedside, clinicians feel conflicted. Obviously you have to pay attention to what's happening with the patient, but also within pediatrics, we do care for families as well as part of what we care for. So having somebody whose primary focus is what's going on with the patient, but having someone, having those people be unburdened with having someone else, like a facilitator, there to help the families to be mindful of their level of state and their anxiety level, and helping them get information that they need in a way that they can understand it, and also dose themselves within the room is very helpful. And what I mean by that is that, parents may start off strong, but over time it's hard to maintain that strength and experience some of what we have them experience. And so they need the ability to be mindful of themselves and have somebody help them understand what's going on, but also take a break and have somebody with them as they walk outside of the room, gather themselves, pull themselves together, get focused, come back into the room. And when you have somebody who's coming in another room, as the clinician, it's nice not having to worry about that. And what parents know and what they don't know, and do they really understand what's going on. So having that facilitator is key to not only helping the families, but also helping the clinicians who are really intent on getting the procedures done well. It was kind of interesting because what we also found in our results was that, children's is a big training has a big training program for physicians and nurses. And in the past, it's like see one, do one, and you're competent. We now use simulation to do a lot of this, but still some things can't be simulated. And so what we also have found that those people who are in training and really want the training and expect people to pay attention to them and give them the training they need to be focused at hand. And having the facilitator allows the people who are doing the training to focus on not only the patient but also the training and everything else that's going on. So it really just helps people find the role that they need to have to make things happen. But we do know it's very stressful for people in training to have families there. But that's kind of what we do in pediatric facilities, is we care for people within a family context. And so if you really want to learn how to do pediatrics, you learn how to do things with families who are there because they're part of what we do.
I think this is a great time to ask our audience and our colleagues out there, do you allow parents to be present during resuscitation and invasive procedures in your unit? And the second question is, if you allow parents to be present, do you use a facilitator to help them be present? When you answer the question, could you please state your city and country? Martha, if you were to repeat the clinician survey today, the perception survey, what do you think the results would be today after having this implemented for so long?
I don't know if we could do this study now because I really think that practice has changed dramatically, in this facility. It's a given that families will be present. When we started this, it wasn't a given. But now we've moved practice to an extent that families are there. It's almost as if thinking that they wouldn't be would be an anomaly. So I don't think I could do this study now because I think we've changed practice. I also think it's kind of interesting because the design was just a pre-post test design with implementation and training in the middle. Recently there was a paper that was published in the adult world in the emergency department, and they really did randomize families to be present or to not. And dramatically there was a reduction in family stress related to family presence in the emergency department in adults for this. So it's always intriguing whether or not you could do like a randomized design, which I don't think you can do anymore because it's not the practice anymore. I think we've hit a ceiling because I really do think we've changed practice. The only thing that I would really want to do as a follow-up to this is to follow up on families after PICU discharge to see the extent to which they were comforted or harmed by being present. We don't know a lot about PTSD in parents after critical illness of their children. We do know that it takes years for families to come together after living through the PICU environment. We know nothing about kids at all, but we know little about parents. So it really would be a nice second step study to really look at following families who experienced their kids' critical illness and all of what that entails in the long run, to see how it's affected them and their families.
Thank you. Well, I want to thank you for taking your time today to speak with us
Thanks,
and our
Amy.
colleagues around the world.
Thank you.
Thank you for your time.